we have time for a series of questions. So maybe first, I would like to see if in the audience, please.
My name is Emmanuel from Nigeria. I'll just make a general comment and then my question. See, when we talk of elimination, it's very nice to hear that, but I think we now see from Miriam's presentation that we should be very cautious in taking this issue of elimination, because in some of these endemic countries, the medical personnel are not even familiar with some of these diseases. I take sleeping sickness, for example, where the state of Nigeria, where I work, was supposed to be endemic was a foci for sleeping sickness. But if you go to the general hospital there, the doctors and the lab technicians don't know anything about sleeping sickness. So if somebody presents with fever, what they test for is malaria, typhoid, or any other disease. So when sleeping sickness is there, it will escape, they will miss it. So when we are talking of elimination, we are still far from that. Because the figure given, oh, this thing is coming down, maybe it's only for situations where these things are reported. In many cases where these diseases occur, they don't even go to the hospital. Sometimes the way it's presented, people ascribe these diseases to witchcraft or voodoo or something else. So it's a serious problem that we need to address. As Miriam is suggesting, we need to have trained people to really know how to even map these diseases. Then my question to her, to Miriam, is, she said the first case of Buruli ulcer was among the Tiv people in Benue State. But in the distribution of drugs that you showed, Benue State was not even listed there. Is that to say where it was first seen, they worked on it, and the disease is no more in that state? Or what happened? Why were they missed out in the drug distribution? Or was it a mistake from you?
Okay. For me again. Okay. Yes, I agree with you on the issue of elimination. It's more control makes more sense. But after all, we have almost been able to eliminate guinea worm. So when we started saying in the early from 1990, 1995 was set as the target for the elimination of guinea worm disease. Of course, it didn't happen then, but at least almost 2 decades later, it has happened. I think sometimes, personally, it's good to aim high, but control makes more sense. But if things are going well as they should, we should be able to eliminate quite a number of these NTDs. About the Buruli ulcer, from the literature, I found that it was first discovered among the Tivs and the Babur in Borno State. But the current status, I don't know what's happening. If it has not been included, since you are from that area, maybe you can make a case.
Thank you. Philippe, do you want to react on the comment on HAT?
Yes, yeah, but because it's an important comment. Indeed, elimination is not something that will come from itself. And especially in countries like Nigeria, like Ghana, Benin, etc., where the disease hasn't been present at a large scale, the skill to recognize the disease, also the skill to recognize the parasite, these skills are just disappearing very rapidly. And this is why when WHO, in the discussions with WHO, when we talk about elimination, we are well aware that awareness is one of the things. And to create awareness, at least you have to take on board the Ministry of Health of the countries where the disease occurs. And education is another keyword. Now, to train people to get the necessary skills to recognize the disease and the parasite, that it's a special exercise. It's not evident, but there are groups working on it, and with the venue of, for example, the rapid diagnostic test in sleeping sickness, it makes it a bit easier. It's not the end of the game, but it makes it a bit easier. But you're right, education and awareness is very important.
Okay. My name is Samuel Jesse, once again from Ghana. My question still goes to Prof. Musa. I think during your presentation, you made some staggering revelations about the extent of the number of affected people with NTDs in Nigeria. Obviously, I'm not too much surprised because Nigeria happens to be Africa's most populous country, right? If I should ask you to summarize briefly, could you say the situational report on NTDs in Nigeria is positive or negative? Do you understand my question?
No, I didn't get the last bit.
I really wanted to ask, if I should ask you to give me a brief summary of the situational report with regards to NTDs in Nigeria, is it positive? Are we doing much to control it, or is it getting out of hand?
No, I don't think it's getting out of hand, because there has been control program, at least for onchocerciasis, for leprosy, for lymphatic filariasis, for a long time. And as people are feeling the impact of these things, and people are involved in sometimes in the treatment, in the identification, and so on. UN mass surveys are being done. People are aware, and government is doing well on some of them. But others, like heart, like Brule ulcer, like leishmaniasis, lualua, there's not much done on them, and probably because maybe they affect just a small area, and such things have to be coordinated, mapped out, and then if the areas are identified, then maybe a control program can come in.
Yeah, I'm sorry, I need to clarify that. This is Joseph Dungo from FIDE. We are working with the Nigeria Trypanosomiasis Research Institute and the Federal Ministry of Health in Abraka State, where we have already installed LAMP. We have installed parasitology in 5 centers in Abraka State, and the rapid test is being distributed in 57 health facilities. We are also working with WHO, who has identified a number of medical personnel in Abraka State, and the plan now is for them to be sent to a country that is more endemic for sleeping sickness for training.
Any other question? Yes, please.
So, I'm Paola Russo from Seoul National University. I wonder if there is enough spread of diagnostic tests. Do you think that the introduction of decision support systems, maybe based on mobile applications, which are widely available, I think, also in African countries, could be a partial solution to the problem of education for masses?
Sorry, I didn't know you were referring the question to me.
Oh,
when
sorry. If there is enough spread of diagnostic tests for some diseases, but there is a few little awareness about the same diseases, do you think an electronic support, so a decision support system, like based on some application, available for mobile, for example, or for web applications, could be a safe or applicable solution for spreading awareness? So one problem is the availability of diagnostic tests, but the other problem is if people don't know, they don't use it. So how to foster education
Yeah, I think this has been happening in some of these diseases. For example, onchocerciasis. If people go to the field to detect onchocerciasis, they don't start looking for skin snips, but they ask for symptoms like leopard skin, like hydrocele, like nodules, and so on. So people can easily identify this, and then you will know that the infection is there. You understand what I'm saying? Like guinea worm, they had pictures of guinea worm, people with guinea worm coming out of their legs. They have the pond, and then they show that to people, and then wherever it is present, as soon as they see the pictures, they know. There's always, whenever these things are going on, there's always, what do you call it? It's always the posters placed, which people can see and identify. There are jingles on the radio or TV talking about the signs and symptoms of these things and what people need to do to prevent themselves and so on. So there's need, though maybe there may be need for more, how do I put it, jingles and so on to sensitize people so that they know what to do, what the diseases are, how they can prevent themselves, and how to report when to distribute, when drugs are to be distributed. You know, because there's some kind of advocacy. Village heads are involved, the community leaders are involved, so they know any time that drugs are going to come to be distributed. So they mobilize the people. When blood samples are to be taken, people are mobilized. So this is what I mean by community participation in some of these things, and I think they have proved to be very useful. And if there are simple techniques, a lot of people can be trained, and it will be very quite useful.
Thank you.
I have maybe a question for Emily, and maybe also for all of you. It's well, very few have used the word eradication in the talk, and probably for good reasons. And what is important is and less ambitious is long-term elimination. I would like to hear of you. What about the impact of asymptomatics in all these efforts? Because you mentioned, among others, the mathematical model, and there are some models like the one that was generated by Tübingen, which suggest that the asymptomatics are probably the drivers of it. And I would like to hear from you about this, and maybe also on other diseases.
Yeah, so this really interesting question is the role of asymptomatics in VL transmission and the role of PKDL patients, and in fact these elimination targets at all. So why are we not talking about eradication? So firstly about that, one of the reasons the NTD modelling consortium has been set up is to look at the elimination target of 1 in 10,000. As you saw in two of my graphs, there's a bounce back in VL after a number of years, after interventions have been withdrawn. And that's because we have a waning immunity in the population and a waning knowledge in the patients and the clinicians' point of view. So one of the tasks is to say, well, is 1 in 10,000 enough? What does that really mean? What, you know, why was it ever built? And then the second point is about the drivers of transmission. So we believe that the drivers of transmission during in endemic zones is KA patients, so symptomatic KA patients. But probably in the inter-epidemic period, then the drivers are asymptomatics and PKDL patients. The Stauch model that you refer to is an individual-based model, and the one that Warwick and we are working on is going to be a cohort model, and so probably the role of asymptomatics will be present, but it won't be such a high level as the Stauch model predicted. In the NTD modelling consortium, every disease has 2 modelling groups that kind of coming at the modelling from 2 different viewpoints, so using 2 different models to see if we get robust answers, and that will be one of the main points is these asymptomatics. It's really difficult at the moment. We have no xenodiagnostic work to really find out who's driving transmission. Work in Brazil shows that dogs with high parasite load are much more infective to sandflies than dogs with a low parasite load, so there might be some kind of parasitemia relationship. But at the moment, we can't tell, but it is something we're addressing.
Philippe, do you want to comment on that also?
Yeah, thank you. First, on the eradication, I think as long as the tsetse fly is just circulating in sub-Saharan Africa, we cannot talk about eradication, because this is the transmitter, and we know already for Rhodesiense that there is a very important animal reservoir, and not only in domestic animals but also in wild animals. So, or you kill all these wild animals, you treat all your domestic animals, and you eradicate the tsetse fly, and then you will speak about eradication of sleeping sickness. Now, for Gambiense, the situation may be different. We don't know exactly what is the importance of the animal reservoir, but there may be one. We just don't know. What we know is that when we concentrate our control measures on the human population only, we can knock down the prevalence to very low levels. But then if you don't do anything for a couple of years, it's back again. That we know already. So now, whether that is due to the animal reservoir or whether that is due to asymptomatic carriers, what we call the human reservoir, we also don't know. And then I think when we talk about elimination, we should always be aware that there is this let's say, source or possible source of new infections. And the only way to tackle that is to develop drugs that can be given to any person who is testing seropositive, where you don't need absolutely to find the trypanosome. When you have this kind of drugs, and they may come, there is a good hope that within a couple of years we have these drugs, so that we can immediately, when a person comes with symptoms and with a positive RDT, for example, that you can put this person on a treatment, and then you will control these asymptomatic carriers also.
Okay, thank you. Professor Suleiman, do you want to make a last comment?
No, okay.
Then maybe, do we have time for final question?
Yeah, I have one last question.
That will be the last, the very last one.
You have to introduce yourself as well.
I'm Fred from Ghana. And my question goes to Emily. I'd like to know what your thoughts are on the role of environmental factors in predicting transmission, because the vectors are quite sensitive to temperature, humidity, and so on.
Yeah, so we also don't know much about the life history of sandflies, in fact. I've been to a talk recently where they found them on top of trees, whereas actually we thought before that they really only hopped not very far. So we need to know a lot more about the sandfly vector themselves. There's a lot of work, and Gates are really pushing vector control in terms of indoor residual spraying. And they're changing the chemical that they're using at the moment. And so that is a kind of a second kind of intervention. The problem is we don't actually know when people are getting infected. So are they really being bitten and infected at home, or is it when they're working? Is it when they're out of their house? So we need to know a lot more about the vector and the environmental effects on that vector before we can answer those questions.
Okay, thank you. I think we should stop the session now. Thank you, everybody, for your input.